Welcome to this evening's seminar and webinar about simulation to improve and prepare for infectious disease. I look forward to you all having a great session today. You might see a pop-up window with some initial surveys we are trying to do, and we might see some of this along the session today. I welcome you all to please participate, give us your feedback and thoughts as this progresses. Before I get into the whole session today, firstly, I'd like to extend a very warm welcome to all of you out there. In particular, despite the challenges of COVID-19 and others, are at the front line doing a lot of hard work to keep us all safe, to help save lives. So I want to especially send a thank you to all of you. I also want to say a special thank you to the panel who has arrived from multiple countries across Europe. We have Peter Dickman from Denmark. We have Kjetil Torgersen from Stavanger, Norway. We have Libby, as well as Verity from the UK. So thank you all very much for joining us and agreeing to share and spend time with us here this afternoon. Before we actually get into the bulk of the session, I wanted to talk a little bit about the situation and the conditions we are in today. As you're all well aware, COVID has taken a lot of our systems by surprise. We actually have a lot to do, a lot of challenges in front of us. And I question and wonder whether we prepared. Are we even preparing to be prepared? I do know many centers, many cities are looking for ways to help support more patients in hospitals. There are shortages of beds in many cities. We are looking at setting up temporary hospitals or instant hospitals in some areas, particularly in Bombay and such. I think the physical infrastructure setup is actually the easy part. The more complicated part with all of this is, do we have the resources? Do we have the ability to run these centers effectively? And I think today's session that talks about simulation and how it can help you prepare for infectious disease will go a long way for us to learn that and understand from the experience of the panelists to be able to take this forward. So today's seminar, while it is about simulation, I wanted to share a few words about Laerdal as well. So for those of you who have not met me before or don't know me, my name is Sivaram. I'm the Managing Director of Laerdal here in India. Laerdal, many of you would be familiar with, but maybe some not so. Laerdal is a company that is headquartered in Norway and has been in simulation and skills training for many years. We are currently the world leader in simulation-based training. Our story is an interesting one, and I like to share it with all of you. The company started because of an incident that occurred with a young 2-year-old boy, the son of our founder. He unfortunately had drowned in a pool of water, and Osman Laerdal, the founder of this company, pulled him out and did something. We don't really know what he did, well over 70 years ago. And whatever he did saved that little boy. And that resulted in Laerdal, Osman Laerdal, deciding to try to do something about it, working with many doctors in Europe as well as in the US. He created, with all of their input and participation, the world's first CPR mannequin. And that set this company on a very different path. It set it on a path not only focused on training and education, but it set it on a path where the mission of helping save lives became the primary lens through which we did anything and whatever we needed to do. With that mission comes a lot of this educational activity that Laerdal is very actively involved with in the country. And we're very happy to present this evening's session with you all that takes this further forward. I'd like to now invite my co-organizers of this event. We have two co-organizers for this program. Firstly, Datta Meghe Institute of Medical Sciences and the Simulation Society of Nepal. I thank them both for supporting us in this endeavor and look forward to not only their participation here, but also continuing to fly the flag of simulation in India. I will quickly introduce Dr. Mahendra, who represents Datta Meghe Institute of Medical Science, and request him to say a few words of the work that they have been doing over the course of the last several weeks. Dr. Mahendra, please.
Dr. Mahendra, you're muted.
Thank you, Siva. Greetings to all my friends, colleagues, and dear students. Hope everyone is fine. It gives me an immense pleasure to co-host this webinar. Datta Meghe Institute of Medical Sciences is a premier institute located at Wardha district in India. National Assessment and Accreditation Council, that is a NAC, has awarded university with A+ grade. The university has medical, dental, nursing, Ayurveda and physiotherapy colleges. We have a 1500 bedded hospital with state-of-art facility. University started Simulation Center 2 years back. It is a AHA accredited and successfully running all the AHA courses. The American Heart Association awarded our center gold medal, that is first and leading in India for training maximum heart savers in the year 2018 and 19. So at these testing times, when the entire world is facing healthcare crisis due to COVID-19 pandemic, our simulation center at Datta Meghe Institute of Medical Sciences University has taken up a task to train healthcare workers in the district. Who are these healthcare workers we are training? They are doctors working as medical officer at PSC, nursing staff, paramedical staff like ward boys, attendants, and security guard. Till now, we trained around 300 healthcare workers in a period of last 40 days. The training consists of 12 hours module for doctors and nursing staff. It's divided into 3 days, 4 hours for 1 day. We're taking 2 batches in a day, one at morning and other at the afternoon, because they have to adjust, they have to go to their duties too. The training is consist more of a hands-on than a didactic lectures. This module is prepared according to guidelines issued by Ministry of Health and Family Welfare, Government of India, WHO and American Heart Association. I'll brief you about the training part. The first day we train them on how to approach a healthy individual or a suspect or asymptomatic COVID patient. It includes hand hygiene, donning, doffing and scenario-based training on SIM-MAN, which is a high fidelity mannequins for asymptomatic or mildly symptomatic COVID patient. On day 2, we train them on setting up a ventilator and the airway management. The airway management mainly by non-invasive positive pressure ventilation manner. On day 2nd, we run a clinical scenario of moderately symptomatic positive COVID case. Day 3, the training is mainly focused on severely ill COVID-19 patient who comes with acute respiratory distress. In our training, the main motto is to encourage the participants to perform than to listen. And few other things which we are addressing in this trainings are disposal of PPE, biomedical waste, cleaning and cleaning of other medical devices which was being used during a treatment. Then transport of COVID-19 patient is a big mess. Even the packing and the handling over of a dead body of COVID patient has to be taught. So we have designed a pre-test and post-test with feedback form to improve our training and to generate research data. So based upon our feedback from the training, the divisional commissioner has praised our university and proposed to train more healthcare workers from adjacent district to combat COVID-19. So more number of workers will be trained in coming months. In future, we are looking forward for more intense integration of simulation in the field of medical education. I feel collaboration with West will make us more mature in this field, which is actually a baby in our region. So I really thanks to Team Laerdal, Simulation Society of Nepal and all the panelists from West for their valuable efforts, guidance and time. So that's from my side. Let's fight together against Corona. Be safe, stay safe. thank you very much. I hand it over to Siva. Thank you,
Thank
Siva.
you. Thank you very much, Dr. Mahendra. It's really appreciated the work all of you all are doing out there. Fantastic to see the simulation center that you have coming along nicely. I would next like to invite and introduce Asmita, who is the Director of the Simulation Society of Nepal, and let her. Thank you very much. Ashmita.
Yeah, thank you so much, Shiva. We're really proud to have this opportunity to host this event. In the context of Nepal, modern simulation was introduced since the last couple of decades, and it has grown from strength to strength. However, the efforts so far have been in multiple small islands and in silo trainings like the Helping Babies Breathe. So we established the Simulation Society of Nepal last year in 2019 to strengthen the journey of medical, nursing and midwifery education in the country, to be able to produce competent and employable healthcare providers so that we can work as an effective and an expert team once they go for clinical practice too. We strongly believe that doing this is a cornerstone to improve the overall healthcare system and also the health indicators in the country. Since the establishment of the society, we have initiated multiple activities to strengthen simulation-based education in Nepal, mostly involving hospitals and educational institutions. In partnership with UNICEF Nepal, we are implementing a key program in the hospitals of Province 2, which have the most alarming maternal and newborn health indicators in the country. And especially during this COVID pandemic, we have been supporting our partners like GIZ, universities, training centers, in developing videos in Nepalese language related to the COVID management, and also implementing simulation-based trainings on different scenarios for management of the COVID cases. Members of our society are also involved in managing patients on the ground and have been traveling to the most vulnerable areas to manage COVID cases and also train the healthcare staff there. So I'm sure that this session would be extremely valuable for all of us. And I hope each and every one of us would take away maximum learning from this webinar so that we are able to transfer whatever we learned into the real clinical practice. Thank you so much for the opportunity. Yeah.
Thank you very much, Dr. Ashmita. Really appreciate all the work you all are doing up there in the north. It's fantastic to see a small country like Nepal embracing this and simulation a reality over there. Thank you very much. So without further ado, I will be inviting our panelists and our moderator to start the main part of today's session. I would like to welcome Dr. Rashmi Aradhya, who is our Education and Project Implementation Manager in Laerdal. So Rashmi, can I request you to take over the session?
Yeah, sure. Thank you so much, Siva. A very good afternoon to all the participants, all the panelists, our co-hosts. Very proud to say that we have almost 300 participants from India, Nepal, Bangladesh, and Sri Lanka listening into this webinar today. Thank you very much for having made the time. It just sort of renews our belief that how important this topic is and how interested people are to come in and get more guidance around this. Before we start, I'll start with a few housekeeping tips for this webinar. What we've done is we've muted all the participants. However, if any participants wants to ask a question, please use the question and answer section which is there on the screen. Your questions will be answered at the end of the session by our speakers. However, a few of the questions could also be answered by the speakers in the chat box during the session itself. So keep a watch on the chat box as well. And at the end of the webinar, the video of this webinar will be made available to all of you after the session. Let me introduce you to our eminent and esteemed speakers who are also the authors of this paper. A very, very warm welcome, and it's an honor to welcome you, Peter Dickman, Kjetil Torgersen, Dr. Verity Bushell, Dr. Libby Thomas. I'm sure all of you have gone through the paper already, the use of simulation to prepare and improve responses to infectious disease outbreaks like COVID-19, practical tips and resources from Norway, Denmark, and the UK. The lead author of the paper, Peter Dickman, thank you so much for being with us and addressing this wonderful group of about 300 people from 4 countries. Peter Dickman is a senior researcher at the Copenhagen Academy for Medical Education and Simulation in Denmark. Peter is a work and organizational psychologist. His research interest is in the use of simulation and experiential learning and research methods in the interest of patient safety. He focuses on research on simulation and research with simulation. Outside of simulation, Peter works with the medication safety and clinical debriefings. He's also he has been a co-supervisor for 4 PhDs already, and he's currently also involved in co-supervising 3 PhDs. Peter has a strong experience in train-the-trainer courses, teaching healthcare professionals to work effectively with simulation, as well as in courses on conflict management and psychological safety. Peter's own PhD work was on using simulation in anesthesiology. He is invited inaugural fellow of the Society for Simulation in Healthcare, the SSH. Peter has been the past president of Society in Europe for Simulation Applied to Medicine, that is CSIM. A warm welcome to you, Peter. Let me introduce you to Kjetil Torgersen, who's the manager of, who's a co-author of this paper. He is the manager of external training programs and senior facilitator at the Safer Simulation Center in Stavanger in Norway. Kjetil has 24 years of experience from EMS at the Stavanger University Hospital. He's currently writing his master thesis in the pre-hospital critical care master's program at the university in Stavanger. And he also has an education in organizational leadership. He has been working with medical simulation since 2006 and has been educating paramedics, nurses, physicians, medical teams for emergency medicine and patient safety. A warm welcome to you, Kjetil. Introducing Dr. Verity Bushell and Dr. Libby Thomas from the King's College Hospital in London. Dr. Libby Thomas is an emergency medicine consultant at the King's College Hospital and a senior lecturer in medical education at Queen Mary University in London. Dr. Verity Bushell is a medical education and simulation fellow at King's College Hospital, London, and also registrar in geriatric medicine. Dr. Libby and Dr. Verity together were actively involved in developing, delivering, and leading COVID-19 simulation across the hospital at King's College Hospital before moving on to use their expertise at NHS Nightingale London to prepare the London workforce for treating COVID-19 patients at this 4,000-bed field hospital. A warm, warm welcome to all of you, eminent speakers for the day. I'll now hand over, without much ado, I'll now hand it over to Peter Dickman to take this webinar ahead. Over to you, Peter.
Thank you very much for the very kind introduction here, and I just have to find my title slide here. And then thank you for taking the time to listen to us. We are very honored to have the opportunity to actually share some of the experiences that we made and try to boil down into practical tips from the different countries. We are only representing a larger group, so there's more co-authors on the paper. Sigrun I think is listening, and Hege also contributed a lot to the paper, and also the people on the paper. We are representing larger teams. So we have the honor to present work that is actually based on many shoulders. The idea for our part of the webinar is actually that I would set the scene with a few overarching thoughts, from a work and organizational psychological aspect. And then Kjetil and Libby and Verity will kind of share the experiences first from Norway and then from the UK. And trying to kind of, contextualize these more abstract thoughts that I will be presenting in the beginning. So when we step back a little bit, I think it's always interesting and important when we design simulations to kind of think about what type of situations are the people that we design the simulations for working in. What is their challenges? And especially in the COVID-19 cases, but all the time within healthcare, clinical care is sensitive to errors. Patients can be harmed, relatives can be harmed, healthcare professionals can be harmed. And especially in these situations with the COVID-19, there's a high personal risk also for healthcare professionals. And Verity will, I think, come back to this and Libby in their presentation, what that actually could mean in daily practice. Stakes are high, so we want to actually avoid doing the errors because the stakes are high. And the clinical environment is even more risky to train in, also for the people who are actually the recipients of the training. So this is kind of a prime, almost textbook example where simulation can play out some of its strengths. And one way of conceptualizing this would be that simulation allows to reduce cognitive load because people in the simulation have to care less about being infected, for example, on their own. It's not zero risk to getting affected during the training, but it's much less than actually training in the clinical environment. By taking away some of these thought processes or reducing them, the cognitive load would go down, and actually there's the possibility then to think more about what is it actually that we should learn on different levels, basically. And when we were approached also in the beginning of the crisis in our hospital system in Denmark, but also the experience in Stavanger, and I think it reflects many countries, the primary impulse is to think about what we call the educational focus. That also reflects simulation practice in most countries, that we think about who do we need to train in what, so that they actually can function quickly in a new position or in an already existing position. As an example, how could we train nurses who are working in regular wards that they're actually able to use some of the intensive care equipment that would be needed here? How would you train people to don and doff personal protection equipment, PPE? So this is, I think, what we often think about using simulation, training somebody in doing something. That is obviously, and I think also the literature supporting this, a very important and effective way of using simulation. I think the current situation emphasizes two more aspects that can actually supplement this educational focus. The system focus, where we use simulation to actually optimize, for example, the workflows, to find out around bottlenecks, dependencies, inconsistencies. And there's many examples where kind of description of standard working procedures were tested in simulation before actually being issued then into the healthcare systems. So where it's not about training somebody in following the guidelines and following the standard operating procedures, but where the SOPs are actually developed in simulation, tried out different versions of this, what is advantages and disadvantages, where we kind of lift the learning away from the individual onto a more organizational level. And I think, again, we will hear more examples from both countries here. And I think there is something where we have a chance to also kind of set a new focus, enlarge the focus that we have. And the last focus that I think personally is a huge window of opportunity in the moment is this, what we call the personal focus, that we actually also use simulation to highlight the intense work that healthcare professionals do, the intense pressures that many of you are under, not only in dramatic emergency situations, but also every day, basically. You know, the little pressure seeing impressive cases, for example, that might actually build up over time to become quite a heavy burden. And I think this window of opportunity is to lift some of the issues that are in the moment in what we call the personal space into a professional space. As an example, the emotions that you might have, the fear of being infected by yourself, for example, during treatment, the fear of spreading the infection to your family members when you get home from the hospital as a healthcare professional, for example. I think in the moment, the window of opportunity is that people actually accept that this might be a burden, an emotional burden on your shoulders. And I think we have the opportunity to actually try to discuss how can you deal with this burden on a professional basis, lifting it into the professional space. And I would hope that by legitimizing talking about emotions in the moment, that this could have a spillover effect until after the crisis situation, where we also take it seriously that healthcare professionals are doing work that is often emotionally straining, and that we maybe can actually use simulation to set up situations like this, and especially also our debriefing skills to ask people, how do you deal with this? What is effective ways of integrating challenging experiences into your professional life, for example. So I think there's a big chance that we have from the current situation. Another angle that we are very interested in, also in and beyond this situation, is different levels of thinking. So there is work and there's challenges in the work, and we are all good problem solvers. So many of the problems I have during my work, I solve on my own. I think often we tend to forget that humans are not only human error creators, but human error problem solvers. And we are capturing many errors, for example, our own, or also in the team, maybe the problem is so large that I cannot handle it myself. So I ask my colleagues for a question and the I becomes a we. And then there is also the level of the organization. And I think what's very interesting in the moment is that organizations become more sensitive to moving from the problem-solving approach into organizational development. And I think as simulation centers, we can support this movement to kind of not only in citation marks trying to help the individuals and the teams to solve problems, but to also think if we change something in the work system, if people, for example, get different equipment, if they get different work processes with the equipment that they have, some of the problems might actually be solved on a more systematic basis. And we will come back to this in what we call feedback loops, and we also described a lot around this in the paper. So I think as simulation teams, you will see some issues that is relevant for your participants that you have in the training. But what you saw with them is potentially also relevant beyond the individual context, so that you always should think about, in our view, who in our organization, in our department, in our hospital, in our healthcare system should know about that this team and or other teams actually had a problem in doing a certain approach. So kind of always think about what we can learn from this situation to potentially enlarge to the whole work system. Also, this notion of what Eric Kohlnagel calls work as imagined versus work as done. So a lot of the procedures that you have is on the basis of work as imagined. people who have written the procedures, they necessarily have to kind of make that a little bit abstract, and they think that they know how all the different work teams are working in the different contexts, but how it actually unfolds is 99.9% of the time slightly different. You are adapting algorithms, for example, to this patient, to this situation. So there's always this difference, and simulation can make us sensitive to this difference and help us to design work processes that actually take work as done in practice into account. One way of doing this is to kind of really systematically thinking through the 6 different aspects that any kind of activity has. The input is basically what triggers an activity, and the output is what you want to get out of the activity. So for example, donning PPE, you want to be protected, you want to protect the patient also. Then there's a time aspect. How long does it take to don PPE? Is there a sequence that you should keep? Obviously, you should take it on before you meet the patient and chat. Maybe you can come back to that with the ambulance people, when to don and off the PPE. The control means what is the official guidelines, what is also the unofficial culture, and that is not always in the same direction. Sometimes they are contradictory. What are prerequisites before you can actually start doing this? Do we have enough equipment, for example? And what are the resources while you are doing things? So you can follow the link here that is on the paper to really kind of think about, how would we support work as done in practice in the treatment of COVID-19. It would be very interesting to think about what are the activities and then the 6 aspects of each activity around that, and trying to design scenarios that systematically vary these aspects, or also try to, in a debriefing, to discuss these different aspects and see, how did people perform in this regard. So to summarize, what I think is very important for any kind of good simulation would be a very deep and relevant needs analysis. The more that we know what people we have, in what tasks they are doing and in which context, the better we will be able to design scenarios that actually help them in their work as done in clinical practice in the various contexts. And the better we can also help them in our debriefings to actually have a discussion that is usable for them than in their practice. So much a few more abstract concepts here. Now I will turn over to Kjetil to contextualize them first with the experience from Norway.
Thank you, Peter. There's the slides. You could just take the next one. What I want to talk about is the context which we did our work in, the request we got from the hospital, how we organized the work, some examples from the activities that we created around these to prepare our hospital for the COVID-19 scenarios, and also some of the challenges and enablers that we faced during our work. SAFER is a simulation center that's were established as a foundation in 2006. It is a collaboration between the University of Stavanger, the Stavanger University Hospital, and Laerdal Medical. From this year, actually, we have a status of being the National Resource Center for Hospital Simulation in all of Norway. And we have formally been a regional resource center. So that is quite a big thing for us. Next slide, please. It is important to remember that this situation is not something that one country or one population is facing. We are all in the same boat. We are all facing the same challenges. If we are working in high resource environments or low resource or mid resource environments, we face many of the same challenges on a personal level and also at an organizational level. Next slide, please. This is a picture from Spain, one of their IFEMA field hospitals. This is a hospital set up in a sports arena, very much like they set up in London. And I guess you will hear more of how they did that in London from the next presenters. I don't think anyone were prepared to face a situation with shortage of basic equipment like we actually faced. Even though we work in what we like to think of as high-resource healthcare systems. We faced shortage of staff, ICU staff. Many people from Norway had been on holiday skiing in the middle of Europe, coming home from holiday, being put in quarantine or infected with a virus. So a lot of healthcare providers could not provide healthcare services. We faced a lack of respirators, ICU beds, protective gear, medications, and even oxygen. This is something that our systems never prepared for. Another big challenge was the lack of evidence. This was a new situation. It was a new virus. No evidence-based protocols were in place, and as they started to come, we needed to almost daily update the protocols. The protocols is one thing, but they are worthless if the healthcare providers do not know them. So that was a big challenge, how to communicate protocol changes to the healthcare workers. And also the hospitals needed to reorganize their wards. We needed to allocate larger areas for ER and handling of COVID-19 patients. And both the wards and the staff needed to do reorganization of how they did their work. Next slide, please. At a personal level, there is also some quite unprecedented challenges. Healthcare providers need to psychologically prepare for a situation where a lot of patients will die. They need to do tough prioritizing between patients. We do not have the resources to treat all patients requiring ICU treatment. Palliative care might be necessary for patients that normally would be salvageable. Long shifts in a hostile environment, working bedside with COVID-19 patients in full PPE, personal protective equipment, that is a very tough situation to be in physically. It's warm, it's hard to breathe, you get dehydrated, and in Norway that is quite uncommon, I can promise you that. We live in a cold environment with a lot of water, so we never get dehydrated. But suddenly we were in a situation that healthcare workers got dehydrated during their work shifts. Every procedure takes more time than normal, and in addition, the environment represents a danger in itself. The healthcare providers are exposed to hazards that put them in risk of the infection. World Health Organization have identified those hazards to be pathogen exposure, long working hours, psychological distress, fatigue, occupational burnout, stigma, physical and psychological violence even. This is things that healthcare providers worldwide face during these situations. We are also facing a situation where many patients require airway and respiratory support that produces pathogen carrying aerosols, which expose the healthcare providers to the virus if no protective measures are taken. The last and maybe one of the most important things is that healthcare providers in these situations need to do decision-making beyond the written protocols. How do you know that you are making the right decision when the normal supportive system for decisions are not available? there's a shortage of doctors. We had a situation where paramedics needed to do more decision making, which would be normally decisions made by a doctor. How could we prepare people to face these personal challenges? As Libya and Verity will address later, that they came up with a system for how to work with these challenges in the aftermath. So simulation could be a tool which could improve these organizational and personal challenges. Our article mainly focused on the organizational perspective, but I think there is a need to do a follow-up of these personal challenges, which also Peter mentioned, because it is a very important part of the whole picture. Next slide, please. In a situation where many healthcare providers were called to work, we know that several other simulation centers had a situation where their staff were needed in the clinical work, so their hospitals prioritized their resources to do clinical work. Our hospital did not do that. They asked our sim center and a group of local simulation experts to focus helping the hospital preparing to meet the pandemic in a prepared way. So we got this request from the lead chief medical officer, which you can read. They basically asked them to help setting up simulations and training to prepare for the situation, both on an individual and an organizational level. So we used a lot of resources to create training for personal protective equipment, setting up and simulation of treating patients in new environments with the reorganized wards, and training personnel to do new tasks in this new environment. Next slide, please. So what we did was we collected a group, I think we were 13 or 14 people working full-time with simulation in this with this task, and we started doing a review of the hospital's COVID-19 emergency plan. We dissected this plan and searched for areas that were suitable for training, and we designed simulation or skill training from the results of this dissection. We used our network of facilitators in different hospital departments to discuss our ideas and learn about their learning needs. It was important to meet their personal and perceived learning needs. As Peter told you, there was a lot of emotions. People were afraid while being at work. They were afraid of taking the virus home and infecting their families. So it was very important to meet these perceived learning needs. We developed training and simulation interventions using a variety of pedagogical tools to prepare the organization and the individuals for the situation described from the first slides. We did traditional simulation training. We used peer-to-peer training. We used cognitive training methods like a model called shadow box method. We used simulation-based training programs based on the circle of learning with e-learning, skill training, decision-making, and team simulation training. So we did a lot of high-quality simulation interventions. Next slide, please. So this is some of the examples of the activities that we created, and also some of the different pedagogical methods used for different interventions. As an additional bonus of these activities, the organization also got to do a system probing where they tested their protocols, and that led to actually to several changes as we discovered things that were not that had not been discovered without the simulation. One example of that of this is what we did for the ambulance service. Where we timed the donning procedure and found that it took between 5 to 6 minutes to do this according to protocol, and that had actual practical implications. When should the paramedics do the donning? Before entering the ambulance, en route to patient? Everyone agreed that it would look kind of stupid if the ambulance rolled up to a house with sirens and blue lights just to use 5 minutes to put on PPE before seeing to the patient. So most of the time, donning are done en route to patients. So that was a practical implication of our training. We also did a quite extensive program for preparing doctors to assist in ICU with respirator patients, and that was made as a regional or national course and rolled out and being shared to other hospitals and other areas of the country. And there were also some interest of doing national sharing of this program. Yes, we also did a lot of pandemic pop-up awards, which I told you about, with staff training, just-in-time training, and we also did quite extensive training of donning and doffing of all hospital staff, and that was in a hospital with many thousand employees. That is was one of the most challenging things that we faced. How could we reach all the persons needed to train in an effective way? I think again what they did in London is an example of how you actually could scale up these things and really do effective training for a large number of people. Next slide, please. So this is some examples of the training that we did. As you can see, we needed to be creative because personal protective equipment like mask there was a shortage of them, so we needed to do something creative. So we make mock-ups of these for rehearsal use. We also designed different simulation trainings for different kind of wards, as you can see. We identified gaps, and one of the challenges is when you identify a gap in a big organization, how do you handle the gap and how do you close the gap? We had quite good ways of reporting it back to an organizational level. Since the request for help came from the medical lead, we had no problems of addressing it, and also I think many of the hospital healthcare providers actually experienced that when they addressed a problem or an issue, a gap which had been identified during the simulations, they were suddenly now in a situation where things actually happened. Normally in a hospital, if you address something, nothing will happen. Things will stay the same, and the same mistakes will be repeated time after time. Many times it is like this. But suddenly things started to change, and I think that was highly motivating for many of the staff at the wards. We did directly report back to the organization. We also did weekly presentations where we did summarize internally, and we also had the hospital organization in these weekly presentations. And we also did national meetings where we shared our experience with other hospitals from around the country. Next slide, please. So one of the challenges that we faced was the silos in a hospital, and especially in a time of high stress. The silos becomes very strong. And it's difficult for people to think on a macro level. They tend to address the micro things inside their own ward. So to have collaboration and creation of a shared mental model, that was a challenge, which I think we were able to work quite efficiently with, because we have a lot of facilitators in the hospital, and we have worked for many years with the hospital wards and with these facilitator resources inside the hospital. So by using these relationships, I think we succeeded in having these collaboration between the silos. Yes, next slide, please. And the enablers, as I told you, there was a sense of urgency. There was a highly motivating situation on a personal level to actually do the training. We had volunteers contacting us and the hospital, asking how they could help in the situation. And one of the things that they helped with was to sew simulated PPE masks. Suddenly, it was not an issue to have different goals for different wards. It was quite easy to sell in the major shared goal to prepare the organization. So when you have one major goal common for all the people in the organization, it is much easier to do the changes that are needed to face the situation. The face trust and relations, I think, also was an important enabler. Like I told you, the long work with the wards and the facilitators inside the hospitals results in us having both the face trust and a lot of the relations inside the hospital. We also have clinical backgrounds, most of us working in the simulation center, and that also enables us to use relations from many years of clinical work to communicate and to facilitate the changes and the interventions that we needed to do. Yes, and the established culture for simulations I already mentioned, and I think it is also one of the most important things that the request came from the leadership. So that enabled us to feed back the results and initiate the changes needed to tweak or customize the organization to face the situation in a more efficient and proper way. I think this was my main message to you. I will give the word to Verity and Libby. Thank you for listening.
Good afternoon, everybody, and welcome. Thank you for inviting us live from London, as they say. Verity and I are here together, socially distanced apart at the same table, but a bit of distance behind at our own computers. And when we wrote the paper with Peter and Shetel and everyone, we were basing it on our work that we'd done within our own hospital trust, which is a large trust in South London, serving significant population. And we were expecting to take a large brunt of the COVID. We did max out at over 600 patients who were COVID positive at one time within our hospital, and 120 who were in intensive care. Luckily, we've now discharged over 1,000 patients successfully from the hospital, and we're left with 42 COVID patients in the ICU still, and I believe about 100 across the rest of the hospital. However, having helped prepare the hospital there and done our work, we then moved to a very exciting project working across London as part of an amazing team at the Nightingale Hospitals. And we thought it would be more interesting to share with you the story about Nightingale and about this sort of large scale simulation as part of this webinar. So that's what we're going to do. I must say that this has been a huge amount of teamwork, and we've had fantastic leadership, and we have worked together in a very sort of shallow hierarchy. But what has been unbelievable, and looking back at your slide, Shetel, about silos, and that is how this pandemic and this tragic times we're living in have allowed us actually to really come together and work in really collaborative ways that we've never seen before. And there's been such an impetus and a drive and a desire by everybody to do something that's helpful and good and benefits society, that actually we've managed to put away a lot of that silo thinking and put it to one side, and to actually go for one thing as a group. So representing the work of our team and just a representation of it. So to put it into context, I don't know if many of you have been to the UK before, but here's a map of the UK, and on the next slide, and I'm based in London, which is obviously the capital of the UK. We're the largest mega city in Europe, I believe, or something. And so we've had our own significant problems with COVID here in London alone, let alone across the rest of the UK. At the last count, we've had over 36,000 deaths from COVID in the UK, which is not a great number. And even though our positive numbers of peak cases is about 250,000, we did stop testing for a long period of time during the peak of the outbreak. So who really knows what the number of cases were that we've had. So anyway, London and the UK were recognising that we could potentially be heading in a direction with this pandemic that was looking like the similar trajectory that was seen in northern Italy and other places that have had it badly. And we recognised we had a significant shortage of intensive care beds across the country. And so there was a request made to try and create a situation where we could increase our ICU capacity rapidly to prepare for the onslaught that we thought was going to be happening. Along with this, not only was the need to physically get the beds and physically create a space, but of everything that comes with actually creating a new hospital, and a field hospital that's not just 50 or 100 people, but potentially 4,000 people. So there was obviously the staff that needed training. And given the pandemic and the environment, there was a lot of risk, people's personal risk about coming to work in this situation, people not wanting to go back home again after they'd worked in high-risk COVID areas. You know, they wanted time to be able to make sure their families were safe, and the stress and psychological pressure everybody was feeling by the potential onslaught. In addition to those issues we knew we had to deal with, like the poor outcomes that were being reported from COVID-19 and the high death rates, which is unusual. We wouldn't expect such high death rates amongst our intensive care patients normally, or amongst our flu patients. And obviously in the UK, we're very used to dealing with seasonal flu. So those big elements that had to be considered as part of the project. They recognised as this is a new hospital, we needed to have a generic induction to the site. So not only were we trying to teach people and remind people of what fire beds and to make things work properly. So we also had to train up non-medical staff in order to do this. So as we can see on the next slide, we went to find some venues that were large enough to set this all up, which was found for us by the Army. And at the top is EXL, which is a huge international exhibition centre, which is where the hospital was based and where our training was based initially. There's my colleague Verity, who you're going to see in a minute, standing outside the hospital. And then having started our training initially within the Centre Ed at the MXL, we then had to move to a larger facility for reasons including the number of participants we needed to train and also to maintain social distancing and prevent the spread of COVID-19 amongst our team. So the next slide, we can see that these two centres are located on either side of the Thames. So they're very close by, but there is a cable car that goes across the Thames between the two, but actually that's been closed. And there is a tunnel, luckily, that goes under the river for cars. So you can get from one to the other within about 15 minutes. So the XL is a capacity of about 70,000 people, and it hosts big shows, it hosts boat shows, it hosts several sports during our Olympics in London in 2012. It hosted Comic-Con and things like that. And then where we moved our training to was the O2, which is a 20,000 person capacity arena, because obviously all these places were lying fallow because of the lockdown and able to use. So we took an arena that's normally used for the likes of Rod Stewart or NBA basketball or ATP tennis tour, and turned it into a training facility, which was an interesting challenge. But what's really important, as I said before, was the teamwork and the collaboration and the breaking down of the silos. So if we look at the structure and training, on this next slide, we can see that we were taking lots of inputs from various people, not only from the clinical team, also from the quality and safety team, from multiple subspecialties such as radiology and pharmacy. And we were trying to get all their requirements and all their needs. So this was a balance from requirements for mandatory training through to actually this is how we're going to run things in this place. We're going to have a turning team, we're going to have a intubation team, we're going to have a cardiac arrest team. What does that actually mean? What does that look like? Who's going to participate in it? And then we had to think about all the different elements. So what the educational content was, how we developed that and delivered it. And actually what we've really been doing and how the systems work so well is that it's been a really iterative and constantly evolving program. So unlike times in hospital trusts when often things can feel quite sludgy and take a long time to instigate change, we were working on 24, 48-hour cycles of change where there would be maybe an incident in the clinical area and they would recognise that actually there was a lack of knowledge coming through, and it was quite widespread rather than just single incident, and we needed to look at the training we were delivering and make sure that it was fit for purpose and we could respond to that. Likewise, as they changed the SOPs, we had to think about how that fed into what we're doing. We had to recognise that where we thought people would be able to adapt quickly to ICU charts and how to document observation, as actually this was more challenging than we thought. And so we had to sort of bring this into our training and make that work. So we were constantly working between the clinical team and then also with our faculty and our participants and making sure that any of their experiences that they had, they fed back at the end of each day. We had briefings and debriefings and we talked about what had gone well and what hadn't gone well and what we needed to change, and actually could we instigate these changes, what would it look like for the overall program. Because when we were building this, we were anticipating staffing the full 4,000 beds, which would have mean training thousands and thousands of staff. And so we were looking at a program of inducting and training anything between 250, 500 people a day, which is obviously much larger than most of us are used to having to deal with. So these are all important questions. So what was the space that we used like? So people find this quite interesting, I think. So if on the next slide, we can see this is the large arena, which was the sort of the center of where we set up our training. On the right-hand side of the screen, you can see that we used the stage, had a little stage set up there, and we used seating in the main arena, but we had to socially distance everybody, so we could only ever use every other row, and we had to use every third seat within any row just to fit people in. So actually fitting 400 or 500 people in took in the space that's equivalent to 3,000 people. So that's quite interesting when you start thinking about that. We were able to build simulation bays, which we could use for multiple purposes, but these we represented the bays that were actually in the Nightingale Hospital and what it looked like on the clinical floor. So that was great, because actually it was giving people much more of an experiential opportunity to really partake in what they were going to be seeing and starting to understand the ICU, how it was going to look in Nightingale terms, because it wasn't a typical ICU. It was actually going to be 42 bedded wards, which were just 21 bays on one side, 21 bays on the other side, in a full long line, open to each other. And then these repeated for 2,000 within one large hall. And then we tried to use the space creatively as well. So here we set up a couple of pods, as you can see, for teaching skills on the arena floor. And we ended up using these for clinical skills training, for basic life support, and various other things as we went through the program. Now, the arena also has a large area, it has a large backstage area, it has large concourse areas, which is normally where the food and the drinks are served. And then it has sort of executive suites and things like that. So on the next slide, we can see an overall floor plan, which is a sort of schematic of it, and you don't need to see the close detail of it, but all these blue spaces were all different rooms that we use for different types of training. And what we had to do was work out the best spaces to deliver this training. We wouldn't normally teach communication skills in a locker room that's been used by the NBA basketball team, or we wouldn't normally be teaching compassionate care in a dressing room. And actually, what was the size of the space? Could we find, one of the challenges we found was finding some warm enough space which actually had carpets and felt sort of comforting for having very difficult conversations about end of life care, or for talking about psychological well-being and things like that. And so that was very balanced out. We recognised we didn't want to do that in the middle of a large arena on cold concrete floors. So you can get these spaces, but it's actually how do you use the space effectively? And one of the best things we moved was when we moved up into level 2 into the private executive suites, because we could actually fit sort of small groups of 8 to 10 people in each suite. We could have 3 suites for one station, such as airway, and they'd rotate around between each of those. So it allowed us to maintain social distancing at the same time as continuing the teaching. So what were we trying to deliver overall, and what did this look like? So we can see on the next slide, this is a sort of a generic overview timetable, and this is part of our purple stream, which was for the people who actually didn't need any specific clinical skills. They were going to be administrators, they were going to be working as technicians in their normal role, they're going to be working in the mortuary. But even anybody going to work in hospital had to have the basic induction, and they also had to have, we felt they needed some opportunities to have certain discussions that were important going forwards. So they all got PPE, and we did fit mask testing as well within the arena, so that we didn't have to waste time doing that when they went into the hospital site. Everybody had a session on communication, and this was looking very much at things like non-verbal communication, challenging hierarchies, closed loop communication, because we recognized these were going to be stressful situations they were working in. We were worried about the noise levels of being in basically an aircraft hangar equivalent, and we needed to make sure we could address that properly. We were worried that if we had a mass oxygen failure, we didn't have a backup system because it wasn't a normal hospital. So we needed to train everybody to be able to grab a bag valve and attach it to an ET tube and ventilate a patient should there be a significant problem with that. Likewise, everybody got some basic life support training for cardiac arrest. And how did this look in terms of doing it during PPE, and what was this like if you're doing it with somebody who was prone as well and intubated at the time? So that we could get all hands on deck if there were significant issues. And the final 2 generic areas that were really important and were developed here within the Nightingale programme and have been exceedingly well received. One was called psychological PPE, and this responds to one of the questions that was put through on the Q&A. I think hopefully, but actually we talk about you put on your PPE to go into a difficult clinical situation and to protect yourself from COVID-19. But actually when you're putting that physical PPE on, you need to protect yourself mentally, and actually how am I going to psychologically prepare myself for this situation and the buddies I'm working with. And then when you come out of that situation and you take off your PPE, you also need to think about taking off your psychological PPE. How are you going to download? How are you going to debrief? How are you going to de-stress? How are you going to prepare yourself to go back to normal life? Or how are you going to prepare yourself to be able to go to sleep? You probably had a very difficult day and had lots of challenging situations. So psychological PPE has been a really important thing here. And the other thing we found we had to develop after the first week was a specific session on compassionate care and end of life care, because this kept leaking into lots of the other sessions. People were really concerned about it, and so we decided to address it directly by having open conversations discussing about the death rates and mortality and what people were potentially going to witness. The next slide shows you some of the other skills and technical skills that we dealt with. So we tried to divide things up into sort of systematic way, and we turned it into an airway breathing circulation and then fluids in and fluids out style program. So people rotated through these different stations, and depending on their level of experience, they had to do differing amounts of this. If people had worked previously in ICUs, then they weren't expected to go and learn how to look at an ET tube and wash it and clean it and change it. But for people who weren't, then these were actually really important basic skills they had. We also taught people about proning, because this has been shown to be really important in the management of COVID-19 patients. And then blood gas machines as well, because these weren't the ones that we use standardly in hospitals. Each hospital in the UK seems to use a different system, so we need to make sure everybody had opportunity there. One of the other important non-technical skills I discussed previously as well was documentation and actually pharmacy, and getting used to the drug charts we're going to be used, because we've mainly used electronic prescribing in National Health Service. And so actually going back to written drug charts as a challenge, and what was actually pre-prescribed, what was in syringes that were ready to made up, what systems did we put in place to mitigate error and to make sure that in these stressful situations patients receive the best care. There's a few photos on the next slide that show some of our stations in action, and some of my colleagues at work. So we've got Balance here, we've got somebody in full PPE, which was actually for doing some filming we did, because we couldn't afford to use full PPE for all of our participants. It wasn't appropriate when the country and the world was having a shortage of kit. We can see the documentation station happening there at the bottom, with lots and lots of paperwork out and trying to prepare sort of tabletop simulated exercises. We can see people standing around a simulated bed at the top and trying to maintain some social distance there, which created issues with the space that we used and we did things in. And you can see some of our hand signals that we were trying to instigate and to bring into our health service, so that we could communicate more effectively if the noise levels were really loud. Luckily, they weren't as bad as we thought. I'm going to hand over to my colleague Verity, who's going to talk about some of the challenges we had.
Thank you, Libby. So yeah, I'm going to just talk about some of the key challenges that we've experienced throughout the process. On the next slide, you'll see that one of the challenges that we had was trying to recreate the ward space. So we found that as our participants came through, one of their main concerns was, what did the Nightingale Hospital intensive care look like? Unlike in normal hospitals, we weren't able to sort of go in and show them. They weren't able to see it before they started work. So it was really important to us that we made the simulation bays as realistic as possible to a true Nightingale ward. And you've already seen pictures of it, but there's some more detailed pictures there. So this is where the simulation took place. And those bays were as realistic as possible to the true Nightingale Hospital. So the Army came in and built those bays in exactly the same way as they were in the Nightingale. Next slide. So another challenge was obviously PPE shortage, and I believe that most countries across the world have had the same issue. And we found it very challenging trying to train huge volumes of participants in PPE donning and doffing without the supplies. So very early on, we did actually have enough PPE for each person to be able to don and doff. But very quickly we realised that the supplies within the United Kingdom weren't enough for us to be able to continue. So we came up with a few different methods for training PPE without each person donning and doffing. We did at one point trial doing it on a large stage with a demonstration at the front. But unfortunately, this didn't get good feedback. We felt that the really important areas of donning and doffing weren't highlighted enough in sort of a large-scale demonstration. So we went back to small groups with a demonstration, and then sort of 10 or 20 people watching that demonstration. We were able to use some equipment, so just simple aprons and surgical face masks. So we still did, each person still practiced with some PPE, but obviously not the full PPE that they would be wearing on the wards. And also on that slide, you can see a picture, that's our proning station. So a group of people practicing proning. One of the problems we found is that in the proning station, people weren't able to socially distance like they were in the rest of the stations. So on this station, we encouraged people to wear a mask because they weren't able to socially distance. Next slide. So the whole reason we moved to this massive arena was because of the problems of social distancing. So we had to train, as we sort of were training more and more numbers of people, our original location of the Excel just wasn't big enough for us to do that whilst everyone stayed 2 meters apart. So we moved to this massive arena and made sure that everyone was at 2 meters apart at all times. So you can see there our induction on the main stage of the O2 Arena, where we blocked out every other row, every few chairs, so that everyone spread themselves out. And you can see there on the top right is our PPE station with everyone socially distanced. And at the bottom, that's our clinical skills area. So we had this really large space where we were able to spread out our stations enough that everyone was socially distanced. We also put up signs everywhere. You can see our Nightingale logo there with the 2 Nightingale birds 2 meters apart, reminding people to stay away from each other. And on the next slide, Libby's already talked quite a bit about this, but just the challenge of adapting a space. So trying to adapt, a music venue into a training centre was quite a challenge. And that explains why I'm currently sat in the dark, because I'm actually sat in our main operations room here at the training centre. But actually, this is normally a bar, hence the sort of very dim lighting. And we had to sort of transform a lot of areas into training areas. So in this picture on the right, you can see, sorry, on the left, you can see some people sat in a box that overlooks the O2 Arena, and that turned into our catheterization station. And one of the challenges with transforming these spaces was that some of them were quite small. We had hundreds of people coming through each day, so we had to split all of our participants into small groups, which actually led to huge logistics, like problems with the logistics. So we had to recruit large volumes of volunteers to help us move all these hundreds of participants through multiple stations throughout the day. So on the next slide, you can see that we trained. So this slide was as of sort of the 30th of March. So it's slightly outdated. Since then, we've trained almost 2,500 participants through the Nightingale Training Centre. And this box just shows who we've trained. So we've trained all different specialities. Basically, every single person that's sort of gone to work into the Nightingale Hospital of all disciplines and specialities has come through our training programme. So on the next slide, one of our other challenges was trying to keep track of the large volume of participants coming through. We obviously logged everyone in the morning and logged everyone out at the end of the day, but we also had to make sure that they were actually participating in all the stations. We had to be sure that they weren't just sort of checking in, not doing anything throughout the day and then just checking out at the end. And this was actually quite a concern to us at the beginning. How did we make sure that they were engaged throughout the day? We then found something called the CAT QR, which is the Classroom Attendance Tracker. And by putting a QR code at each station, so for example, the compassionate care station, the proning station, the PPE station, each participant with their mobile phone could scan the QR code at each station, and at the end of the day we'd have that person and know exactly which stations they had gone to and which ones they hadn't. And that worked really well at ensuring that everyone had attended all the stations that they should have. Okay, so on the next slide. So this, of course, was a huge team effort. And here is a list of some of the people that have been involved. So the Nightingale Hospital has actually now closed in the United Kingdom. We have sort of over our sort of the peak. And 2 weeks ago, our Nightingale Hospital closed. We did continue to do some training for people that were still sort of registered, and we finished our training a week ago. And this sort of closing down of the education centre has brought about some of its own challenges, one of which is that we have so much simulation kit and equipment that has been borrowed from multiple sim centres across the whole of London. And part of the challenges now is trying to return that to where it came from, and that process has sort of been ongoing throughout the last week and a half. So thank you very much for listening. Thank you.
Thank you very much. So I think I would turn over to you again, Rashmi, for question answer session.
Sure. Thank you so much, Peter, Jetil, Verity, Libby. Wonderful, wonderful learnings for all of us here. So let me direct some of the questions that have been coming in and not answered so far. Sharda Acharya from Nepal. It's a very relevant question. In case of children, how do we provide care to a child and how to deal with patient of an infected child? Do you have any guidelines? So not really a clinical guideline, but did you address this as a part of your simulation exercise, Libby and Verity? Yeah, please. Libby?
We did pediatric simulations in the hospital, yes, at King's College Hospital, because we treat a lot of peds patients as well. So we found we did simulations both in the A&E department and also up on the wards and things like that. So yeah, we did run the simulations within that in order to just get everybody used to the PPE and limiting the number of people who turn up. I don't know, in our hospital, when we have a pediatric cardiac arrest or pediatric trauma call, it feels like the world and their wife come to the situation. And so we actually had to learn how to manage that and reduce the numbers, partly for social distancing, partly to reduce the amount of PPE used, and partly because it's actually very scary for the children when they're being approached by all these people wearing the masks and everything else. So that was a key issue for us. And I think, like everybody else has said on this webinar, key lessons were learned on how to move things forwards from running the simulations, because actually we could see where the issues were and the sticking points. So that was important.
Yeah, thanks for that one, Libby. There's a question from Dr. Ramana Rao about what were the challenges that you faced with training EMS teams, emergency medical services. Again, can I direct it to Jetil?
Yes, you can. The main challenge, I think, was that the workload of the EMS system was already peaking. So to find the time for the training, I guess, was one of the most challenging things. People were highly motivated, but at the time when we started the interventions, they already started to show signs of fatigue. So I guess one lesson learned is that we should have done the interventions even earlier.
Thanks, thanks, Jetil. We have a question from Bandana Thapa from Nepal. So there was a concept of psychological PPE when you were talking, Libby. So would you want to explain a bit about the psychological PPE, taking it off at the end of the work hours?
Yes, I'm not the expert in it. This was run by some colleagues who are specialists in clinical psychology and psychological occupational therapy and things like that, and they developed the program there. But actually what it was really about was getting the groups to understand what their fears were, what their stresses were, what they found were going to inhibit them from doing a good job, and also getting people to recognize about the ways they relaxed and they could they could actually de-stress as well, and that was a really key part of it. And so thinking about actually what would you normally do under normal circumstances, and what are you still able to do under the sort of the lockdown circumstances in order to manage your mental health and to get yourself better prepared for it. There are people in the process of writing this up so that it can be sort of better shared in more detail. But those were really the two sort of key aims of it. And so it was getting people to talk openly and to share with each other as well what their concerns were, which we're not always very good at doing. You know, it's a classic, how are you? It's like, I'm fine. And it's like, well, what does fine mean? You know, it doesn't mean anything. And actually, what are the questions we should ask each other's colleagues? What's the non-verbal language we should be looking for? And actually, if you can even have these conversations with the people you're working directly with in your team, then you can start to recognize when they're getting overloaded, when they need further support, or maybe even when they need some time out and to be taken off the shop floor. So that was a really key bit about it. Within the Nightingale Hospital, there was a huge emphasis on the well-being, to the extent that within the hospital, we were very lucky. We were sponsored by various companies, so there was free drinks and free food at all times, which is not usual in the National Health Service, but actually it goes a long way to making people feel cared for. There were breakout spaces which had psychologists on hand and people wearing lanyards which were a well-being colour, so they knew who they could go and talk to if they just wanted to talk to anybody about anything. It didn't have to be about work, it didn't have to be about COVID, it could just be as a distraction. And that was really important. And then there was a pressure which we needed to try and mitigate, put on the sort of the senior leadership teams within the clinical areas to try and debrief their group and to understand everybody's pressures at the end of the day. But I think what made things work better within Nightingale is they could see that we were reacting and responding to the changes and to the issues. And because we were constantly trying to turn around and make the training better and to listen to their concerns and to see what we could do to make things work in a more effective way, I think this actually helped because people felt much more positive about what they were doing because they felt they were listened to, and if there was an issue, then changes were made rather than being told to put up and shut up and carry on as normal, which can be sometimes more of the attitude that happens within large organisations. So I hope that helps a bit.
Yes, of course it does. Yes, Peter.
Yeah, just a supplement. The Danish Nurses Foundation, I think they actually had a nice element in this psychological PPE, and that was a sentence something like give yourself the permission that you do not perform 100% as you are used to do because of all the strain and so on. You give your best, but your best might be lower than it usually would be. And to consciously give yourself permission to do that, to be able to think, you know, within this crisis here, we all give our best, but we might not reach what we usually do. I thought that was quite an interesting element in this here. And the other point I think would be important, you know, that this psychological PPE is super individualized. So yours does not fit me, right? Kind of to really take it seriously that people are very different in their psychological needs and their psychological scoping mechanisms and so on, and to take that seriously. How did you deal with this, Libby?
Yeah.
Dr. Harish Kumar, who's the project director from IPE Global in India, is running a project on KMC, and he has a question. The WHO is recommending KMC to be KMC is kangaroo mother care to be continued by a COVID positive mother to a COVID negative newborn, which generally hospitals are not agreeing to in India. So what's been your experience in the NHS and both in UK, Denmark, and in Norway? It's a question to all of the panelists. I mean, anyone can answer this one.
I mean, I think it's important. I've seen a few clinical questions coming through here in this panel is about discussing educational strategies and training to try and improve rather than as a sort of an expert panel on the clinical care of COVID-19, I'm afraid, because that's a completely different situation.
Yeah. Okay.
I don't think it's appropriate to be necessarily responding to questions.
Yes. Let me pick up a question that is coming from Dr. Ashok Badamali. What he's asking is how did you manage to integrate multiple COVID units for training on simulation, which is geographically different? So typically what happens is every district in India or in Nepal, like, have got so many geographical differences that it's quite difficult, like, to bring them all together and be able to train. So how did you manage to sort of, overcome these kind of a challenge, if you had one, while you were doing so in these 3 countries? A question open to any one of the panelists, actually.
So I think it's really important that all the information between different, areas is shared as much as possible. And I think that's something that we try to do at King's Hospital in London. So it's just things like, using contacts between the different hospitals, setting up WhatsApp groups, or some sort of, text groups between you all. And I think the key is just about sharing all the resources that you can share as much as possible. So that's, whether that's simulation scenarios or videos that have been made. So at King's Hospital, we made some videos quite early on, sort of intubation videos in a COVID patient. And we made sure that we shared those. So we didn't keep them just within the trust, but we shared them as much as possible. And I think that's
through social media.
Yeah, so through social media. So it was actually on YouTube, and I think that's key. It's not about keeping these resources to yourself. It's just about sharing them, as much as possible.
Yeah, I think that also sort of takes care of the question that Swaraj Rajbandari from Nepal is asking about whether do you have any videos of training and simulation, like, which they can review. Maybe it would be nice if there is a link or something that's put up on the chat box for all of the YouTube links that you're talking about, if that can be put up on the chat box for the participants to review. There's another question that's also coming from Swaraj Rajbandari, whether were there any e-learning or online sort of a training also which was done?
Yes, we developed several e-learnings related to both COVID-19 and the use of PPE equipment. And we also developed some specific methods for doing cognitive training to prepare people before they came to our center and doing simulation. I answered Dr. Ramana Morao in the chat as well. He asked on the same question about blended learning. And what we used to enable this blended learning and e-learning into a simulation context was a method developed in the US called shadow box method. It's a way of doing cognitive skill training, to decision making.
Thanks, Jatil. A question from Ashwini Suman to Peter Dickman. She's asking about a corridor of normal performance in terms of task or variety of approach, and also systems improvement in this case here. Finding a balance between learning and providing systems improvement. Peter.
I think the corridor of normal performance is something that you would actually then see by seeing different people performing similar scenarios. I think Shetal has a good example of how long it takes, for example, to don and doff the PPE. I think it might be nice that you come back to this example, that you actually consider this time, for example, that you also, by running different sessions, kind of see how do people actually move when they don doff, what is their approach in, for example, there was a question of psychiatric patients, how would you actually interact with somebody? What is the different approaches here? And I think simulation, by bringing many people through, gives you an idea of this corridor of normal performance by seeing many people in the similar situation. And then you get an idea of the bandwidth, how do people approach this? And the balance between learning and system improvement, I think in each session it would make a lot of sense that you concentrate on this person, on this team, and you try to help them learn as much as they can. What I think should be in the back of your mind is what you have seen with this person, with this team in terms of strengths and weaknesses. Who else should you inform around this? And in what way would you need to prepare the information that they can actually react on this in an effective way? So in me, that the balance comes in that you probably would need time after a training session to process what did we see and to then make a strategy, who should we inform around this. So ideally, I think you would plan a little bit of time after the sessions, after training days. Jetta, could you maybe share the experience with the donning and doffing in the ambulance?
Yes, I think I mentioned it in my presentation as well.
Yeah.
But the practical problem that the paramedics were facing was that it actually took quite a long time. And when you are responding to a critical emergency, those 5 to 6 minutes, when should you do that? Would it be the best way to put on the protective equipment before even entering the ambulance or en route to the patient? Because when they first did the simulations, they did not do these procedures before they arrived at the patient. And you can imagine the reaction from relatives and the public if an ambulance arrives and you use 5 minutes to put on protective gear. That would rise quite some emotions. So that is something that they had to deal with when they actually did the timing. And we did not plan for that timing. It was just a good suggestion for one of the participants. So to be able to join these sessions where they are training these simple procedures, which everyone basically thinks that they know, is quite important, because we could, when the question arose, we could take that into a discussion and bring it on to the managers, the ones who are writing the protocols, and ask them to change the protocol based on what we learned from the training experience. If we did not have any facilitators present, that issue and that gap would probably just have been discussed right there and then, and would probably not be taken any further.
Thanks, Jethil. We have a question from Dr. Ditimoy Datta from Malaysia. Typically what happens is the medical students who are undergoing their clinical rotations during this period, what was your experience in all of these 3 countries? Were they also considered for simulation trainings, which was like a regular part of their education? Or, and also how were their clinical postings sort of managed during this period? Any comments on that?
So in the United Kingdom, it does differ from university to university and hospital to hospital. But for most medical students, their clinical rotations stopped and all their learning went online, and a lot of effort has been put in by universities to get huge volumes of lectures and stuff all onto online platforms. When it comes to final year medical students, they actually finish their final year examinations in April time, and therefore they have been able to start on the wards already, and that kind of process is happening around now, and they have undergone specific training which has included lectures and simulations to get them ready to work on the wards earlier than they normally would have.
Yeah. Thanks so much. And Sorry, hello. Yeah, we have a question from from Gajanan Chavan, who's Professor EMD and Director SVL, JNMC Wardha, India. His question is, a lot of the physicians are afraid and taking active part in COVID-19 management, managing actual patients. Were there any scenarios that you designed as a part of the simulation to be able to motivate these kind of scared healthcare providers, physicians, and all of that as well? Question to any or all of the panelists.
Yes, I don't think we actually created a scenario, but the feedback that we got from participants after doing in situ simulation at the hospital was that their level of anxiety was significantly reduced after the training, so they felt more confident and lesser degree of anxiety for these situations when they already had trained for the situation.
So if I have to rephrase what you're saying, Jetil, is that just get these physicians to run a few simulations and they would be motivated and confident enough?
Yes.
Yes. We have another question from Dr. Harish Kumar, and this is a very relevant question to this part of the world. In India, Nepal, and the neighboring countries here, we have, first of all, not too many ventilators available with a lot of the ICUs, and also the men behind these machines. Like, we don't have enough respiratory therapists, so we don't have enough experts to be able to actually run these ventilators, even if we buy new ventilators in this time of COVID. So his question is, what was your experience in UK and Norway and Denmark? Especially more so in UK, because I think you had quite a challenging situation also. That were you able to manage to train people quickly on ventilation who had never been trained earlier? And because many of these centers are going to get new ventilators and find it difficult to use them without the men behind the machine. Your experiences and your thoughts around that.
Well, we had a challenge here at Nightingale because we were being donated ventilators from various sources, so we weren't like having one set ventilator across the whole of the trust, and we were actually using anaesthetic machines mainly rather than ventilators because of the lack of ventilators. The technical problems weren't just with ventilators, but with all the kit. So we were repurposing syringe drivers that hadn't been used in the UK for 20 years and other bits of equipment that people might not be familiar with. So we set up a bank of online videos basically that people could access, like an e-learning platform, but it was talking them through the kit, and they could access all the different types of kit that was being used and put into place, and they had that on their phones because we're lucky most people in this country have a smartphone, and so they could become aware of what was going to be used in their bay, and they could then access the kit on that and actually go through it and repeat it as many times they wanted until they felt comfortable with it. But we also found the need to have technicians available at all times. We had operating department physicians, practitioners who were around to support in the clinical area. We had ICU consultants and anaesthetic consultants who were used to the different things. And we put quite strict guidelines in place about who, so that we didn't have everybody just fiddling around with machines where maybe that would then cause more problems. So that was our Nightingale perspective on that.
Any other perspectives from the other panelists around getting people quickly trained on ventilators using simulation as a methodology? What was your experience like?
Yes, I could add to that. That was one of the biggest projects that we worked with together with the hospital and the university, and also Laerdal to get a program enabling physicians and also retired persons and people who had worked in ICU wards at an earlier time, how to create a program where we could train these people to not be in charge of the respirator treatment, but to assist. So that they could allocate their resources in the ICU wards in a more efficient way. And we created a program, a simulation-based program with an e-learning, a blended method, and we share that nationwide. And I also think that there was, I don't know how if they were able to finish it, but there was talk about doing this in English and make it available for other countries as well.
Wonderful. Thanks, Jatil. I think if it is going to be, yes?
Sorry, may I just add to this? Yeah, I think it's a good example where kind of this third loop could actually come into play. You guys have seen in a very short time a pretty large number of people being trained in these complex machines. So you actually get quite a good insight into which way of explaining these machines to people works better than others. And ideally, you get some insight in, when in peace times again, how do we actually train people to use these complex machines? You're kind of lifting it away from this situation into a more systematic way, even. Kind of, if we manage to preserve these experiences, I think would be great.
Yeah, manage to preserve experiences from this emergency situation and actually mainstream it later. Is that what you're trying to say, Peter?
Yes, exactly, yeah.
Yeah, thanks for that. We also have another question from Dr. Gajanan Chavan. What he's asking is, when you train, so they've had this training of 3 days in their lab, around COVID response for their healthcare workers. So they learn airway, LMA insertion and intubation in simulation lab, but he's asking a question about how do we monitor the skills that they've learned over a period of time, and are there any protocols for monitoring once they leave the simulation lab? What's been your experience, Libby and hello? Libby and Verity, when you turn these NHS hospital into a huge simulation sort of a lab, people came in and people went out. But how were you able to sort of see what they do when after they left? After they learned what they learned in the simulation labs. Was it really transferring into practice or not? Yeah.
So this was something that we found quite a challenge because of the large volumes of people that we had coming through. We weren't able to assess competence of each and every person. We did, however, get feedback from participants, and also feedback from our faculty was really, really important. And as Libby discussed, when she was doing her presentation, she showed us that diagram of that iterative process of our training program. And I think that's really how we sort of, ensured that our training program was teaching the necessary skills and creating competent staff. So it's just this iterative process. If there were any incidents in the hospital, and continuously having that link between the hospital and the education centre, which made sure that our training programme was doing what it needed to do, and teaching staff to be able to use the equipment that they needed to be able to use. But what we didn't do was do individual competency assessments, because that just wasn't possible.
Do you mind my screen? Is that all right, quickly?
Yes, sure.
Come up.
Yeah.
Yeah, so here's a sort of picture of our model, really. This is what we've just developed in the last couple of days, which is why it's not in the slides sets, because we've just been trying to pull everything together. But you can really see we've got this continuum going from our education team briefings and developing the training through to patient care, but we were constantly going through these feedback loops. So we had one set of feedback loops, which was within the education department. So it was through the faculty debriefs and the participant debriefs. Then we had a significant amount of feedback as well coming through the end of shift debriefs from the clinical leads on the shop floor, from the bedside learning coordinators who were there observing, seeing what's going on. And we had another group who were doing sort of skills gap analysis constantly and talking to people saying, what skills do you have? What skills haven't you been trained? What do you need the training in? This was led back to daily forums that were run at 4 p.m. every day, where all the lessons from each day were learned and changes made. And then these were liaised back to our clinical team through a sort of liaison team. So it was a really iterative, constant cycle that was going on. And that hopefully just gives you a bit of an idea about that.
Absolutely, Libby. Thank you so much. I mean, this was this clearly sort of talks about what an integrated way it was to be able to do this whole PDSA cycle, literally, and you know, improving things. Would it be okay if this slide could be added to this, or could be added as a repository to the materials that we would be sharing with all the participants post this webinar, Libby? I think it's a wonderful slide. And a wonderful experience, you know, which can be replicated as well. There's a question from Akriti, who's an MSc simulation student in the UK, but she is from India, and then she used to be leading one of the simulation labs here. So her question is about the post-recovery post-COVID recovery rehabilitation. Have you had any multi-professional scenarios that were designed, you know, when you were training these people, or was it mostly related to the hospital care itself?
It was very multi-professional, everything that we were doing, but it was also very specific to the hospital scenario, because that's what we were training for, and that's who we were being asked to train. So I guess, yeah, we kept it very in hospital, but we kept everything as professional as possible, because, you know, we were lucky we were working a team of like-minded people here, and we all believe that the only way to achieve good patient care is to work interprofessionally, to break down those silos. And I think that's one of the things, you know, our team was led by somebody with a nursing background, not by medical background, which is brilliant. And we had people, you know, a lot of the senior leadership came from within the nursing and other areas. And that was important, you know, it's because they were the best people for the job. And that's what it comes down to, you know, and the rest of us fitted into the team and did the areas that we could contribute in the best ways we could.
Sure. Any experience from Denmark and Norway about post-COVID rehabilitation sort of scenarios, if they were done? Peter, Kjetil?
No, we did not do anything like that in Norway, but I think that raises a very important thing. It is something that we are working quite intensively of getting the communities and the municipalities to start simulation training for the healthcare providers responsible for home care. They could be a very important asset in dealing with this situation, but we have no established system for simulation training or facilitators out there, which could be.
Sure. Thanks so much. Yes.
Similar experience also here in Denmark, but I think what would be interesting, I come back to this window of opportunity that we try in the scenarios that we run after the crisis to also kind of, again, pick up on some of the things that we actually saw as important, for example, emotions, for example, you know, kind of all this feedback loops that Libby also showed, you know, to keep this alive once the crisis is over.
Sure. Thanks so much for that one, Peter. There's one last question. I think this is more around what are the kind of scenarios that you ran, like, you know, so there's a question from one of our participants from Nepal who's asking that when the cases are so many and the number of health workers are very less, and how do you deal with such kind of situations? Were these kind of situations also a part of your simulation scenarios that you ran for preparing these healthcare providers in UK, Denmark, or Norway, while preparing for this COVID-like crisis, COVID situation?
So I'd say in the UK, I think it's in the simulations that we ran, we didn't run anything specifically about sort of low staff numbers and having to deal with that. Yeah. But I think in general, the whole purpose of simulation was to prepare people for this sort of outcome. It's certainly something that was considered in the cardiac arrest scenario, how to deal with a cardiac arrest scenario if there's only one or two of you in the room and everyone else is outside, say being delayed due to donning PPE, and how you think about that process and prepare yourself for that possibility. So even though it wasn't something we did specifically, I think it's sort of inherent in simulation, just sort of preparing yourselves for that potential outcome.
Any other comments from you, Peter and Jetil, Libby?
Yeah, I think I have a comment. It's quite similar. We did not train for those specifics, but what we discovered was that the healthcare providers working outside the hospital, at least, had to be very careful on who they exposed when entering a scene with a suspected COVID-19 patient. Through simulation, they discovered that they had to plan ahead much more than usual. They had to be prepared, and have everything that they would possibly need to face any kind of situation inside with the patient. When entering the ambulance, they had to cover all the equipment not used by plastics. And also they had to anticipate what could happen with the patient and have the equipment prepared. If they were to break the plastic or the barrier towards the non-exposed equipment, they would have to clean the whole ambulance afterwards, and that would take a large amount of time. So there are good examples on how simulation identify these kind of gaps, and the healthcare providers needed to adjust their way of handling these situations.
Yeah, thanks, Libby, Verity, Peter, and Jetil for answering all of those questions. Since we're running out of time, we have 3 minutes more. Thanking all of the panelists, thanking all of the participants for being a part of this webinar. Over to Siva to deliver the vote of thanks. Siva.
Thank you very much, Rashmi. Thanks everybody for that very insightful presentation. I really appreciate all of your time and energy. I think you've done this a few times, so a lot of your sharing has been very beneficial, I think, not only for us here in India and Sri Lanka and Bangladesh and other countries that have joined in on this webinar. So I really appreciate all of your support in all of these matters. Thank you very much. I also want to particularly thank all of the participants who have been listening in. You guys have been very patient, as well as staying on a pretty long call, but I think a lot of value, a lot of interesting insights. And hopefully these connections and networks will extend beyond this. But before you all leave, I do want to talk to you all about something else that's happening next week as another educational event that Laerdal is actually driving at the moment. We will be having on the 28th of May, on Thursday, what we call a global virtual SUN. SUN stands for Simulation User Network. So we conducted one physical one last year. This year, given the circumstances, this is a program that's going to be run globally. So you are fortunately going to have the benefit of having Peter speak in a summarized fashion, I suppose, on what was covered today, as well as Jetil on some different topics, as well as many others. So I would like to invite all of you to join us on the 28th of May. It's at Indian time, 5:30 p.m., European Central Time at 1 p.m. So if you go to the registration link on the bottom and take note of that, you will be able to get to that link and register for it. Furthermore, there is an invitation pop-up that should have occurred on your screens. Please use that also to inform of your interest to join this network, to join the webinar that's happening next week. So without taking any more of your time, I wish you all a really great evening. Please all be safe. Thank you very much once again for everybody on behalf of Laerdal, on behalf of Datta Meghe Medical Institution, as well as on behalf of the Simulation Center of Nepal. Thank you.